Welcome to the deep dive. Today we're doing something a little different. We're going inside the mind of a junior doctor. Specifically, we're looking at this high-stakes procedure, the clinical examination of the abdomen.
And our source material is just fantastic for this. It's an objective, structured clinical examination script, an OSCE script.
Authored by Dr. Senthil Kumaran. And an OSCE, if you're not familiar, is basically a practical exam. It's timed, it's structured. Every single step matters.
It's a 12-section map, really.
It is. It turns, simple actions like looking and feeling into this incredibly precise diagnostic superpower.
Exactly. And our mission today is to unpack the thinking behind that rigor, to show you that diagnosis isn't some kind of magic trick.
It's a method.
It's a meticulous, almost ritualistic adherence to detail.
Right. And we're going to show you why something that seems so small, like making sure the doctor's hands are warm, is actually a fundamental diagnostic step.
Because if you mess up step 1, step 5 is already compromised.
Let's get into it. So, okay. Before any physical contact, there's this whole sequence of foundational steps.
The non-negotiables.
What are the absolute must-dos before the exam even really begins?
It all starts with basic medical ethics and legality. First, you have to introduce yourself, clearly.
And confirm the patient's identity.
Yes.
Yeah.
Name, and date of birth. You have to be sure you have the right person to avoid a catastrophic error.
Of course. And then consent.
Then you get informed verbal consent.
Yeah.
And that means explaining exactly what you're about to do.
Not just, I'm going to examine you.
No, much more specific. Something like, I'm going to look at your stomach, gently feel it, tap on it, and listen with my stethoscope. Please tell me if you feel any pain.
That transparency builds trust right away.
It does. And at the same time, you're setting yourself up for an accurate finding. The setup is key.
Talk about the setup.
You ensure privacy. So draw the curtains, close the door, then you ask the patient to empty their bladder.
Why is that so important?
Because a full bladder can actually feel like a mass. Or it can cause discomfort that you might misinterpret.
Interesting. Okay. And then there's the patient positioning.
The famous positioning detail.
Ah, yes, the knees. Tell us about the knees.
The patient must be supine, so flat on their back, a small pillow under their head, and crucially, their knees have to be slightly flexed.
And why is that tiny bend in the knees so powerful?
Because it relaxes the rectus abdominis muscles.
The six-pack muscles.
Exactly. If those muscles are tense, you can't feel anything underneath. Any palpation will just feel rigid.
So you can't tell the difference between a patient who's just nervous and one who has genuine underlying inflammation.
We've got it. It's the fastest, cheapest way to get maximal muscle relaxation.
So before the doctor even looks at the belly, they do a quick general examination, a systemic scan.
Right. They're looking for signs that the problem isn't just in the abdomen, that's affecting the whole body.
What are they looking for in that scan?
You're looking for things that tell a story. Are they in pain? Do they have cachexia, that severe wasting you see in advanced disease?
And you're looking at their skin, their eyes.
You're looking for pallor, paleness, which suggests anemia, or icterus jaundice, that yellowing that points to liver problems.
And what about like tubes and catheters, external hardware?
You note all of it. Is there a urinary catheter?
Yeah.
An IV line? An azogastric tube? These are all immediate, visible clues that the patient is already significantly unwell.
It's about putting the abdominal findings into a global context.
Precisely.
This brings us to where it gets really, really interesting. Section 2. The art of inspection, pure visual detective work.
Yes. The doctor actually stands back, often at the foot of the bed, to get the big picture first.
What's the first thing they notice?
Contour and symmetry. Is the abdomen flat? Is it distended, bulging? Or is it scaphoid, kind of sunken in?
Which you might see in malnutrition.
Right. But the most critical visual observation is movement. The movement of the abdomen with respiration.
Okay, so what should you see, and what's the red flag?
Normally, the abdomen gently rises and falls as you breathe. If that movement is restricted, or worse, completely absent.
That's a huge red flag.
A huge red flag. It's a powerful sign of peritonitis, that's severe inflammation of the abdominal lining. Moving that tissue is agonizing, so the body just stops. The patient switches to chest-only breathing.
Wow. So just by watching them breathe, you already have a major clue.
The major clue. Then you look closer at the surface. Scars tell you the patient's history. Dilated veins.
The caput medusae.
That's the one. A cluster of veins radiating from the umbilicus, a classic sign of chronic liver disease and portal hypertension.
Are there any specific visual signs of, say, malignancy?
Yes. The source specifically mentions the Sister Mary Joseph nodule, It's a hard lump near the umbilicus.
And that
It's
means...
an ominous sign. It suggests cancer, usually from the stomach or pancreas, has spread.
Okay, so that brings us to palpation. This is where the risk of causing pain is highest. What are the rules here?
The rules of palpation. First, warm hands, trim nails. Obvious stuff. But the most important rule is to always look at the patient's face while you're palpating.
And not at their abdomen.
Not at their abdomen.
Yeah.
Because the face is your feedback loop. It's your monitor for involuntary pain.
They might try to hide it, but a wince gives it away.
A wince, a catch of breath, a sudden frown, it tells you exactly where the problem is.
There's a rule about starting away from the pain, right? Why is that?
That's a great question. You'd think you'd go right to the sore spot?
Yeah.
But if you do that, the patient immediately tenses up. They start girding, and then you can't accurately feel anything else.
You've contaminated your findings.
You've contaminated your findings. So the rule is you start gently in the quadrant furthest away from the pain, and you slowly work your way toward it.
And palpation happens in layers, correct?
2 layers. First is superficial. Very light. You're just screening for tenderness.
And this is where you distinguish between the two types of guarding.
Yes. There's voluntary guarding. That's just anxiety. If you distract the patient, ask them a question, their muscles will relax.
And then there's the other kind.
Then there is involuntary guarding. That's the serious one. It's a rigid, board-like tension the patient cannot control. It means the underlying lining, the peritoneum, is acutely inflamed.
So after superficial, you move to deep palpation.
Exactly. This is firmer, steadier pressure, searching for deeper organs or masses.
And if you find a mass...
You immediately run through a checklist. Size, shape, consistency. Is it hard, soft, rubbery? And critically, how much does it move when the patient breathes?
This meticulous approach leads us right into the specific organ exams. Let's start with the liver.
Okay, the liver. The standard method is very precise. You start your hand way down in the right iliac fossa, the lower right abdomen.
So far away from the liver itself.
Very far. And you inch your way up towards the rib cage, and with each little move, you have the patient take a deep breath in.
And why the deep breath?
It's pure physics. The diaphragm pushes down on inspiration, which pushes the liver down. You're hoping that the edge of the liver will be pushed down and, well, catch on your fingertips.
And that tells you if it's enlarged.
If it's enlarged, yes. Hepatomegaly. And then you note its characteristics. Is the edge smooth? Or is it hard and nodular, which could suggest cirrhosis or cancer?
What if the standard approach doesn't work? Maybe the patient is obese or very muscular.
There are alternatives. There's the hooking method, where you stand by the patient's shoulder and curl your fingers under the rib cage, trying to hook the liver edge.
And the other one is really clever, the scratch test.
The scratch test is brilliant. It's an acoustic test. You place your stethoscope over where you think the liver is.
Okay.
Then you lightly scratch the skin, starting far away and moving toward the stethoscope. As soon as your scratching finger crosses onto the solid liver, the sound is suddenly magnified in the stethoscope.
Wow. So you can hear the border of the liver?
You can hear the border. It's a fantastic technique.
Now, what about the spleen over on the left side? What's the cardinal rule there?
The cardinal rule is a normal spleen is not palpable. If you can feel it, it's enlarged. Period.
And the technique is different.
Similar, but with a twist. It's the diagonal creeping method. You still start down in the right iliac fossa.
All the way over on the right side to find something on the left.
All the way on the right. Because the spleen enlarges diagonally down and towards the right iliac fossa. So you creep your hand up obliquely.
And you're feeling for something specific.
You're feeling for the characteristic splenic notch. It's a little groove on its border.
Okay, and finally, the kidneys. These are deeper, right?
Much deeper. They're retroperitoneal, behind the abdominal lining. So you need a special technique called bimanual ballotment.
Bimanual, so 2 hands.
2 hands. You place one hand flat on the patient's back in the flank and the other hand on the front. The back hand pushes up and the front hand pushes down.
And what are you trying to feel?
You're trying to feel if the organ bounces between your 2 hands. That's ballotability. If you can bounce it, it's retroperitoneal, which almost certainly means it's a kidney.
So this is where it all comes together. A doctor finds a mass. How do they use these maneuvers to tell if it's a liver, a spleen, or a kidney?
The differentiation rests on those specific tests. So a mass on the right side. A liver mass will feel continuous with the ribs. You can't get your fingers above it.
Okay.
A kidney mass, however, is usually separate, and most importantly, it will be ballotable. The liver won't be.
And you mentioned sound can help too.
Sound is a huge clue. The liver is a solid organ, so it's dull to percussion. A right kidney mass, though, will often have a resonant note when you tap over it.
Because there's bowel in front of it?
Exactly. The air-filled colon lies right in front of the kidney.
And what about distinguishing a spleen from a left kidney?
Very similar rules. The spleen has that diagonal enlargement and the splenic notch. But the kidney doesn't. The kidney is palatable. The spleen isn't.
And sound again, with something called Traub space.
Yes. Traub's space is a little crescent-shaped area on the lower left ribs. Normally, it's full of air from the stomach, so it's resonant when you tap it.
Like a drum.
Like a drum. But if the spleen is enlarged, it fills that space and the sound becomes dull. It's a great confirmatory sign.
Okay, so that brings us beyond touch to percussion and auscultation tapping and listening.
Right. Percussion is used to map out the liver span, which is normally about 6 to 12 centimeters. But its most crucial use is testing for ascites.
Free fluid in the abdomen. And there are two classic tests for this. The first is shifting dullness.
Correct. The patient is lying flat. You tap from the center, which is resonant, out to the side until you hear dullness. That's the fluid level.
And then you have them roll over?
You have them roll onto their side. You wait about 30 seconds. If that line of dullness has now shifted down with gravity, you've confirmed you have free shifting fluid. You have ascites.
And the second test, the fluid thrill, is even more dramatic.
It is. The problem with just tapping one side and feeling for a wave on the other is that fat can transmit that wave. It's a false positive.
So you need to block the fat transmission.
You do. You ask an assistant, or the patient themselves, to press the edge of their hand firmly down the midline of the abdomen.
That acts as a barrier.
A barrier. Now, if you tap the flank and you still feel that wave, that thrill on the other side, that's a large volume of free fluid, no doubt about it.
And then we listen. Auscultation. What are we listening for?
First, bowel sounds, the normal gurgling noises. But pathological sounds are either too much or too little.
What's too much?
High-pitched, continuous tinkling sounds. That can suggest an early bowel obstruction where the gut is working hard to push things past a blockage.
And too little.
Silence. Absent bowel sounds. That's very worrying. It suggests the bowel has just given up a paralytic elis.
The final section is the holistic closure, proving the doctor sees the abdomen as part of a whole system.
Absolutely. This is mandatory. You have to check the external genitalia and all the hernial orifices, and critically, you perform a parectal exam.
With consent and a chaperone, of course.
Always. You're checking for masses, sphincter tone, and looking at the glove for any signs of bleeding.
And then there's a very specific check for cancer spread.
Yes. The doctor must palpate the left supraclavicular fossa. That's the little hollow just above the left collarbone.
And they're looking for what?
For Virchow's node. It's also called the sentinel node. If that lymph node is enlarged, it's a powerful, though late sign that an abdominal cancer has spread throughout the body.
That's a profound final step. And then the doctor synthesizes everything into a summary statement.
Yes, they confirm they've completed all the steps, they state their provisional diagnosis, and then, crucially, they list the investigations needed to confirm it. Ultrasound, CT, blood tests.
This deep dive really shows that a clinical diagnosis isn't guesswork at all. It's not at all. It's a rigorous, logical sequence where every tiny detail, the resonance over mass, the lack of respiratory movement, provides life-saving information.
It's incredible. Thank you for sharing the source material with us. It's been a fascinating deep dive. And for you, the listener, we leave you with this final thought. Reflect on the unique diagnostic value of ballotment, the ability to physically move and feel a deep organ, like a kidney, bouncing between your hands. It proves you haven't just superficially assessed the body. You've understood its three-dimensional internal mechanics. What single, simple technique in your own field best separates that superficial understanding from true, deep expertise?